All right, so homeostasis. So why do we need to study fluid and electrolytes? So it is our job as the nurse that we maintain all of our fluid and electrolyte balances for our patients, right? We want to monitor their intake, their output. We want to make sure that everything is balanced. If we don't have proper fluid and electrolyte balance, our cellular regulation is going to be impaired. All the functions of our body, in order for them to work appropriately, everything needs to be balanced. Pathologies and different health issues that we see that affect people are sometimes caused from abnormalities in our fluid and electrolyte imbalances. For example, sometimes if you have people who are runners or they're exercising, they lose a lot of fluid and then their electrolytes are imbalanced and then they can suffer different signs and symptoms. With older people, sometimes they don't drink enough, they get dehydrated, they present to the emergency room exhibiting certain signs and symptoms of electrolyte imbalances. So we need to be able to, as nurses, know how to treat these patients and what to look for. It's a very fine balancing act, being able to balance what we take in versus what we put out. And when we take care of patients, it's very, very easy to tip the scales. So we may have a patient that is dehydrated and then we're giving them fluid to rehydrate them, but then we give them a little bit too much and then we cause overload. They have fluid overload. So now they have the opposite problem. This happens a lot. We see this as nurses. And then a loss of only 20% of our fluid in our body can actually be fatal. So fluid and electrolytes is extremely important. So composition of our body fluids. So most of our body fluids are solutions of water and dissolved substances. So anything that is a dissolved substance is called a solute. So you guys, this is kind of like a little refresher from anatomy and physiology. We talked about this years ago when we took these courses. So our body fluids are solutions of water and dissolved substances, which are solutes. So water, which is our primary body fluid that runs through our body, this is going to represent about 60% of our total body weight in the average adult. It changes for children. Children are the opposite end of the spectrum. So we'll talk about that later. So 60% water for us. As far as solutes, these our body fluids contain two types of dissolved substances. We have electrolytes and then we have non-electrolytes, okay? This is the composition of our body fluids. So age, we do have variations in a lot of different areas. So age. So in infants, they have an increase in total body fluid and in their extracellular fluid. Older adults, opposite end of the spectrum. Remember, I always say infants at one end, older adults at the other. They're very, very different. Infants have more. Adults have less body fluid because they don't take in a lot of fluid. If you remember back to funds, that mechanism that tells the body that they're thirsty, they lose that mechanism. So they don't drink a lot. So they're susceptible to becoming dehydrated and they lose muscle and it increases the amount of body fat that they have. So they lose water. Body fat actually contains little water. Lean tissue is higher in water. So if our older adults are losing fluid because of muscle loss and an increase in body fat, that means that they're going to have less water. And then, of course, your more obese patients, obviously, are going to have less water. And then gender, women typically have more fat, very unfortunate, but it is true, which means that we have less fluid, okay? So solutes. Electrolytes are substances that are capable of breaking into particles. When they break into particles, they're called ions, okay? The ion is an atom that carries an electrical charge. Cations are ions that develop a positive charge. Anions are ions that develop a negative charge. So the major cations, which have a positive charge in the body, that's going to be our sodium, our potassium, our calcium, our hydrogen, and our magnesium, okay? They all have a positive charge. Our anions, those ions with the negative charge, they're going to be your chloride, your bicarbonate, and your phosphate. These charged particles are the basis of all of the chemical interactions in our body, and we need them in order for metabolism to occur and in order for all the other functions to be maintained in our body. So we also have non-electrolyte solutions, and these are substances that do not dissociate in a solution. And an example of that would be your glucose or urea. So when we talk about our fluid compartments, and this is really important, I need you guys to really understand this, study this, make sure that you understand this, because this is going to help you to be able to determine where all the fluid is when we start talking about fluid shifts and things like that. So this is a really important slide. So we have a couple different fluid compartments. We have intracellular fluid, ICF, so in, that means the fluid is within the cells, okay? Then we have extracellular fluid, or ECF, that is our fluid outside the cell. So when we talk about the fluid in the cell, it's going to be about 70% of our total body water. And then our extracellular is about 30% of the total body. Okay, so if you look right here at this, I don't know if you guys can see this. This is the cell, so anything inside the cell, right, is going to be intracellular. Anything outside the cell right here is extracellular, because here's the cell, and here inside the vein or the artery, this is the extracellular right there. So it is outside the cell. Then we have intravascular. So intravascular is our blood plasma. So that's what's going through our veins. Okay, that's this area in here. And then we have interstitial fluid, and interstitial fluid is between the cells and outside the blood vessels. Okay, so between the cells and outside the blood vessels. That's our extracellular or our interstitial, okay? So here's our extracellular, plasma and water. Here's the cell, that's our intracellular, and then our extracellular or interstitial, okay?
Interstitial was between cells and outside of?
Interstitial is outside of the cells. It's in between, it's outside the blood vessels and between. It's where the fluid is between the cells and outside of the blood vessels.
Got it. Thank you.
Yeah, because there's also cells outside, but then here's the blood vessel. So this little area, when we talk about third spacing, if you've ever heard of third spacing, that's where we see that third spacing shift, is into that little area. This is why it's so important for you guys to really understand this and the locations of the compartments and where things go, because you're going to need that to be able to critically think and decide what's going on with your patient and where all this fluid is. So this is just another picture. This is your interstitial fluid. So here is your plasma, right? This is your vein. This is the veins that we see in our arm. This carries our plasma, our blood. Outside of this intravascular fluid, this is our interstitial fluid. And here's some more cells here, okay? So extracellular is divided into interstitial and intervascular because you have cells inside and outside of the plasma. So outside of the plasma, in this interstitial area, we have cells, okay? Whatever is around this area is going to be your extracellular fluid because it's around this cell. When you talk about like your red blood cells and stuff like that that are located in this plasma, all around that is also going to be extracellular fluid, okay? So it can be in the intravascular or in the interstitial fluid. So intravascular fluid compartment, that's going to be your plasma. So that's going to be about 25% of the extracellular fluid, the liquid component of the blood that's found in our vascular system. That's what plasma is, okay? Your interstitial compartments, that's going to be about 75% of the ECF. And this is the fluid that surrounds the tissues and our cells, and it includes our lymph. The capillary walls and cell membranes, they separate the intracellular and the extracellular compartments. So what are some factors that affect the movement of water and our solutes? So obviously our cell membrane, we're going to talk more in depth about these. So your cell membrane, so what kind of permeability does your cell have? What can get through, what can get out? Our transport processes, how does it go? Does it go on its own? Does it need a little bit of ATP to push it through? We're going to talk about osmotic and hydrostatic pressures. And then we're going to talk about the dynamics of our capillary system. So when we talk about cell membrane, so this is our primary barrier of movement of our solutes in the body. It is a semi-permeable membrane. God bless you. If you don't mind, Nicole, can you just keep your computer on mute?
Okay.
Thank you. Semi-permeable is our cell membrane. It allows some, but not all, solutes to pass through. The cell membrane has pores in the membrane that allows passage of water and very small water soluble substances such as glucose and certain ions. When we have larger molecules such as certain proteins, they are not able to pass through that membrane because they're larger. The cell membrane is permeable to water or fluids and fat soluble substances. So that would be our oxygen or our carbon dioxide. They can pass right through with no issues. So when we talk about transport processes, so how do these solutes get through that cell membrane? Well, some of them occur by diffusion. So diffusion is a movement of any solute in a solution across a semi-permeable membrane, so that would be our cell, from an area of high concentration to an area of low concentration. So high concentration, right? We have a lot of these little blue dots here, these little particles, whatever you want to call them. We're going to throw some more solutes in them and then they disperse equally, okay? So once you put them in there, they all disperse equally. That is diffusion. You still have equal room between each of them. When we talk about osmosis, it is passive movement of a fluid across a membrane from an area of low concentration to a higher concentration. So diffusion is from an area of higher to low, and then osmosis is from an area of low to high. So if we look at osmosis, this is before. So what happens is that your fluid is going to shift with your particles. So you had a couple particles here, you add some more, your fluid is going to go up. So it's going to be from a lower concentration to a higher concentration. Okay, so you still have the same amount of fluid, it's just that it's higher on this side because it's higher concentrated, okay? And then you have active transport. So active transport utilizes ATP, and that is solutes that move against a concentration gradient. So those are your transport processes. So again, this is what diffusion looks like. This is your osmosis. And this is when we do that active transport. So we need something that's gonna put that those particles where we want them. It needs energy to do it. It can't move on its own. So when we talk about capillary filtration, so filtration is going to be the passage of fluid through a permeable membrane. So these are fluids that go from an area of high pressure to one of low pressure. Within our vascular system, only our capillaries have walls thin enough to let solutes pass by. So that's why we call it capillary filtration. This results from our blood pushing against the walls of the capillary. And when that happens, it's going to push solutes through. That push that we see that occurs up against the walls of the capillary, that's going to be what we call hydrostatic pressure. Hydrostatic pressure is just that pushing force, pushing that blood up against the walls of the capillary to make that capillary filtration happen. So if we look here, this is our capillary, okay? On the outside, this is our interstitial fluid around the capillary wall. The pressure within our artery is going to be positive. So when we talk about the left picture here is our arteries, the right picture is our veins, okay? Two different things we're talking about. Pressure inside of our arteries is going to be positive, okay? So it's going to push our fluid in to the interstitial fluid, okay? When we're talking about arteries, when we're talking about veins, the pressure, that hydrostatic pressure inside the veins, is negative. So fluid is going to move from our interstitial area, which is around this vein, into that capillary, okay? This is just another example, how the arterial end has that positive pressure. It's going to force things. This picture right here in the middle, this is our the artery. It's going to push that filtration out because that hydrostatic pressure is going to be positive. And then resorption happens on the venous end because it's that negative pressure. So anything outside the capillary is going to re-enter into the venous end. So if the hydrostatic pressure inside that capillary exceeds the interstitial space, then fluids and solutes are forced out of the capillary and into the interstitial space. So that's when the pressure is positive. When the pressure inside is less than the pressure in that interstitial area, then those fluids are going to move back in, okay? So low pressure in here in the vein, whatever's out here in the interstitial fluid, because that pressure is higher, will come back in. With the arterial end, the pressure is higher in here, it's going to force things out into the interstitial fluid, okay? Now, when we talk about colloid osmotic pressure, this keeps fluid in our intravascular compartment by pulling water from that interstitial space back into the capillaries. So it's going to pull from this outside area around this vascular area. It's going to pull from the interstitial area back in. Okay, we call that colloid osmotic pressure. So reabsorption, or colloid osmotic pressure, is the process that acts to prevent too much fluid from leaving the capillaries, no matter how high the hydrostatic pressure gets. So when fluid filters through the capillary, the protein, what we call albumin, is going to remain behind in that diminishing volume of water that just went through the capillary. So albumin is a very, very large molecule that normally doesn't pass through the capillary membranes. As that concentration of albumin increases in the capillary, fluid then moves back into the capillaries through osmosis. So you guys need to think of albumin as a water, okay? Albumin is going to attract that water. So to put this into an example, if in our capillaries we have low fluid, right? When fluids filters through the capillary, right? We have a diminishing volume of water. This could be low blood pressure, right? Maybe the patient's dehydrated. Our circulating volume is low. What's going to be left behind in that capillary is the albumin. That albumin is then going to attract the water, which is going to build back up that volume and increase your blood pressure. Okay, hopefully giving you that example. And we're going to talk more about that, but I wanted you guys to be able to relate that. So albumin, you always want to think of a water magnet. And sometimes in the clinical setting, when we have patients who are really struggling to keep their blood pressure up, we will give them albumin drips. It's a very easy, you just spike the bag and hang it. It runs wide open. It's probably one of the easiest things you could give. And that way it pulls more water into that vascular area and helps bring up that blood pressure. So this is the pulling force that we call that colloid osmotic pressure, or you can also, some people call it oncotic pressure. It's used interchangeably. These pressures are important because you need to understand how fluid leaves the arterioles and enters that interstitial compartment and then eventually returns to the venules. So functions of water in our body. So it helps by transporting nutrients. It transports electrolytes and oxygen to our cells so that they work properly. It helps excrete waste products from our cells, an example through our kidneys. Water helps regulate our body temperature. It helps lubricate our joints and our membranes. And then it also is going to serve as a medium for food digestion. So we know that as we take water in, we also lose water. This happens on an all-day basis, even if we're not physically taking something in or we're not going to the bathroom. We have sensible and insensible losses. So water, fluid gains and losses, it is just that homeostasis. It's that physiological balance. It's what our body needs to stay in a steady, healthy state. Whenever we talk about fluid gains, we talk about intake. And whenever we talk about fluid loss, we talk about output. So when you see your patients in the clinical setting that are on strict I's and O's, that means that we are watching everything that they take in and we're measuring it and we're comparing it to everything they put out. So things that they take in would be drinks, it would be any IV fluids that we're giving them, it would be food intake on their plate, clear liquid diet or a regular diet, and then our output, that can be a number of things. It can be urine, it can be stool, it can be vomit, it can be diarrhea, it could be drainage bags. There's a whole lot of ways that we measure intake and output. That's just a few. Myself as a nurse, I just treat every patient that they're on strict I's and O's. Usually if the doctors want you to monitor them, they'll put orders in. I monitor all my patients' I's and O's. I've had many texts come to me that say, well, I'm not documenting their I's and O's because they're not ordered. Well, when you see a change in your intake versus your output, that can be a very early indicator that something is starting to occur with your patient. So it's good to be able to see those signs. So just as good nursing practice, I think everybody should be on strict I's and O's. So some normal sources of fluid gain. In general, fluid intake averages about 2,600 mLs per day. It's estimated that about 13 mLs come from ingested water, so water that we drink. 1,000 mLs comes from our food, because our food has different water components. And then about 300 comes from metabolic oxidation in the body. And we always want our input and our output to be as close to equal as we possibly can, because if not, then we have an issue. If they're not taking in enough, then they can become dehydrated and they're going to have nutritional deficits. If they're taking in a lot, but they're not putting any out, then they're retaining fluid or their kidneys aren't functioning. That's why we want to monitor this strict I and O. Our fluid losses. So when we talk about fluid loss, we can have sensible losses and we can have insensible loss. So fluid is lost from our body through sensible and insensible. Sensible losses can be measured, and they include fluid loss during urination, if they have a bowel movement, if they have oozing wounds, any kind of JP drain, if they happen to have an NG tube and we're doing, suctioning from their stomach, things like that. insensible losses are things that we cannot measure or see, and that includes fluid loss from evaporation through the skin. So these are going to be your patients who maybe have fevers, right, and they're sweating, or it can be water vapor from the lungs that we lose when we breathe in and out through our respirations. Any deviation from the normal ranges for a balanced water intake and output should alert us as the nurse that there can be potential imbalances, because whenever the water shifts, we're also affecting all of our solutes, right? So that's why it's so important. So normal sources of fluid loss, it's going to be your lungs, approximately 400 mLs with increased respirations. So when we talk about increased respirations, these are people who are having some kind of respiratory issue and they're breathing normal than that 12 to 20, which is normal, right? So your pneumonia patients, COPD patients, people that are having respiratory issues. Your kidneys, about 12 to 1500 mLs a day. Minimal kidney function. You should see at least 30 mLs output a day, an hour from your patient. That's the bare minimum. Anything less than that, your patient's kidneys are not functioning and we have to figure out what's going on. Losses from your skin, about 500 to 600 mLs, and then about 200 from the GI tract through your feces. So abnormal sources of fluid gain. So remember I told you IV fluid. Sometimes we do this ourselves to our patients. It's a very fine line. We have a patient that comes in that's dehydrated. We start giving them fluids. The doctors kind of lose track sometimes that the patient's still on fluids, or they'll say, Trish, I need you to, Mrs. Jones isn't vomiting anymore. Let's start giving her something to drink and see how she does. But she still has fluids of 200 cc's ordered an hour. And by the afternoon, she's on a full diet. She's eating and she's drinking, and we're still giving her these fluids. The doctors depend on you to kind of look at that and say, hey, I'm advancing liquids. Mrs. Jones is drinking now. We need to call the doctor and say, hey, I think we need to get rid of these fluids. So fluid therapy is definitely an abnormal source of fluid gain. NG tubes. So if you have a tube that's not working properly and the fluid's building up, that can be an issue. Different humidified gases, kidney issues. So if we're taking fluid in, but we have kidney issues and they can't properly filtrate all the metabolic stuff and all the water out, then that fluid's going to build up, okay? And then the same thing with heart failure. So with heart failure, there's left-sided and right-sided heart failure. We're not going to talk about that now, but if our circulating volume, if our heart's not pumping properly and we can't get the fluid out that we need, then it's just going to pool and it's going to build up. And we're going to see that through edema and other things like that. So abnormal sauce there. I keep on wanting to say sauces. I don't know what my issue is. Abnormal sources of fluid loss. So these are going to be your draining wounds, fistulas, any kind of external bleeding that we can see, small children or extra adults that cry, vomiting, diarrhea. And then I talked a couple slides back about that third space fluid shift. So this is loss of fluid to an area that is what we call unavailable for functional use. So that's the interstitial area. So if you look on the slide, look at the middle slide here, this is all the interstitial fluid. So it's outside of the vein there, the plasma, and it is outside of these cells. So it's the extracellular fluid, but it's our interstitial area between the cells. So fluid can shift out and get stuck in this area and we can't do anything with it. It's useful. It's not useful. And the patient gets swollen and it makes them hard to breathe. So we don't want third spacing. We don't ever want to see that in our patient. It becomes trapped there. And it cannot exchange with the ECF fluid. Let's see.
Would that be like edema?
Yes.
Okay.
Yeah, it is edema. So these fluid shifts can come from disruption in that colloid osmotic pressure. So maybe if you see with a decrease in albumin, it can come with increased fluid volume, increased capillary hydrostatic pressure, which we see in heart failure, things like that. So regulation of fluid balance. So we have several regulatory mechanisms that work together to preserve the fluid balance between our fluid intake and output. So these are things that are automatically work in our body to help keep that harmonious state that we call homeostasis. So first, we talked about the thirst mechanism. We're going to talk about antidiuretic hormone. We're going to talk about aldosterone, renin, angiotensin, and we're going to talk about atrial natriuretic factors or peptide. So thirst, this is our primary regulator of water intake. You guys need to know that. This is the primary regulator. The thirst center is located in the hypothalamus. We have osmoreceptors that are in our hypothalamus that respond to a decrease in plasma volume, which is also a decrease in our blood pressure, right? If we don't have plasma running through our body enough, then our pressure is going to be low. And then it's also going to respond to an increase in plasma osmolarity, okay? So decreased blood pressure can lead to hypokalemia. We're going to talk a little bit more of that. So this is our primary regulator. Our hypothalamus is going to say, hey, we need to increase our water intake because we sense decreased blood pressure, or we sense a decrease in our plasma volume, or we sense an increase in our plasma osmolality. Okay, so thirst, the primary regulator. Another regulatory system that we have is ADH, or it's called antidiuretic hormone. It also has the name vasopressin. So you will see these names interchangeably in your book, in different resources. They are all the same. Vasopressin, antidiuretic hormone, ADH. You can think of it as a water retainer. It helps retain water. So vasopressin is produced in our hypothalamus by the pituitary, but our posterior pituitary is going to store it and it's going to release it when we need it, okay? So it's produced by the hypothalamus, stored in the posterior pituitary, and it gets released when we need it. So we have osmoreceptors in the hypothalamus that sense increased serum osmolality or decreased blood volume. When those osmoreceptors sense that, they stimulate the release of this ADH, which in turn stimulates our kidneys to reabsorb water. So normally our kidneys filter out water, right? Well, when we don't have enough circulating volume, or when we're dehydrated and our blood pressure is low, this stimulates the ADH to tell our kidneys, hey, we don't have enough fluid. We need to reabsorb that water back into our body to get it into our bloodstream, into our circulating volume to help build those levels up, okay? So the ADH stimulates the kidneys to resorb the water. The increased water absorption results in a more concentrated urine. If we're not going to the bathroom all the time, our urine, when we do finally go, is concentrated, right? Like the first time we go to the bathroom in the morning, we've been holding our urine all night long. It's more concentrated than it is after we've gone our five or six times during the day. So remember when we talked about those older adults, how they have issues with going to the bathroom? They don't have the ability to concentrate their urine because they're going to the bathroom all the time. I just wanted you guys to be able to relate that because we learned about that last semester. So that hypothalamus is going to stimulate the release of the ADHD. It's also going to act as an arterial vasoconstrictor. The action of ADH is going to be to restore blood volume by reducing diuresis and increasing water retention. So I do have a little video for you guys to watch. Let me share my sound here. Whoops.
What's open? What's closed? What day is today again? It seems like everyone's schedule is hard to predict lately. Well, almost everyone's.
Yes.
Yes.
Okay.
In this video, we are going to break down exactly what ADH is and what you need to know about it for nursing school. And before we get started, be sure to subscribe to this channel and click the little bell so you don't miss out on any other videos to help you totally rock nursing school. Now, let's do it. What is up, my friend? Christina here with NursingSchoolOfSuccess.com, and today in this video we are talking all about antidiuretic hormone, or ADH. So antidiuretic hormone, otherwise known as ADH, does exactly as it sounds. It's an antidiuretic, meaning it's going to help the body retain water. What happens when you give a patient a diuretic medication? They urinate a lot, and ADH is anti-diuretic hormone, so it's basically the reverse of that. They will hold on to water rather than get rid of it. Now, ADH is a hormone that is secreted by the hypothalamus in the brain. And there are really 4 things that I want you to know about ADH. Its whole job is to keep water and fluid inside the body. It's secreted when there is electrolyte levels in the blood get too concentrated because of a low blood volume. It's secreted when the blood pressure decreases because of low blood volume. And it's inhibited when the blood volume or the blood pressure is high. So the body wants to constantly stay in balance, right? That's its comfy zone, homeostasis. It's always trying to stay in balance. So it wants to have a nice balance of fluid and electrolytes. However, when the electrolytes get too concentrated, the body wants to balance that out by adding more fluid. So if the electrolytes are too concentrated, ADH will be released because ADH will go tell the kidneys to hold on to water, which will then increase the fluid volume and dilute out those electrolytes. In the same way, if the fluid volume is simply just low, ADH will be triggered to help increase that fluid volume. Now, on the other hand, if the fluid volume in the body is too high, the ADH level will decrease because ADH is anti-diuretic hormone. So if the fluid volume is too high, the body wants to get rid of that fluid. It wants to diurese and get that excess fluid out. So if the blood volume is too high, the ADH level will go down. Does that make sense? I like to think that you're nodding your head with me as I go through this. So if this is all just clicking for you, write love in the comments below so that I know that this all makes sense for you. Okay, so if the fluid volume is low or the electrolyte levels are high and concentrated, ADH will spring into action and help the kidneys hold on to water. However, if the fluid volume is too high already, ADH will be inhibited so the kidneys can just do their thing and get rid of some of that excess fluid. And that, my friend, is the role of ADH in the body and how it balances out fluids and electrolytes. Now, if you want more help with fluids and electrolytes in nursing school, you will definitely want to check out the fluid and electrolyte course that we've got for you inside of the Nursing SOS membership community. There is a link down below in the description for you to check out all of the details if you're interested. Thank you so much for watching, friend, as always. Now go become the nurse that God created only you to be, and I will catch you right back here next time on the Nursing.
Okay, so if you guys can tolerate her, she's a good person to follow. I like the way she explains things. She's got a lot of energy. So I hope you guys found that useful. I thought that was a good video. All right, so that's ADH. So next we have what we call the renin-angiotensin system. So this mechanism helps the body maintain a balance of our sodium, water, blood volume, and our pressure. So we have our juxtaglomerular cells, which are near the glomerulus. They secrete an enzyme called renin. Through a series of steps, renin is going to lead to the production of angiotensin 2. So what happens is angiotensin 1 causes vasoconstriction, okay? It causes constriction in your veins. Everything gets smaller. Angiotensin 1 is then, when that happens, it's going to convert angiotensin 1 into angiotensin 2. I have this in the notes section for you if you're looking. I just broke it down a little bit for you, which causes massive selective vasoconstriction of all the blood vessels and relocates and increases the blood flow to the kidneys, which will help improve our renal perfusion. Angiotensin 2 then stimulates the release of aldosterone, which increases the absorption of water and ultimately excretes K. Okay, so angiotensin 2 is what we call a very powerful vasoconstrictor. And it works on a feedback cycle. So when the blood pressure or the volume reaches a normal level, then the body's going to stop releasing renin, okay? So this is the renin-angiotensin mechanism. It's gonna cause the kidneys to reabsorb sodium. We know wherever sodium goes, water goes, right? So water's gonna follow that sodium that the body's holding on to, and it's going to increase our blood volume and our blood pressure because we're holding on to sodium, so we're gonna hold on to water. And then when we have enough, that system is going to stop. So we have aldosterone. So aldosterone is a hormone secreted by the adrenal cortex in response to a fall in blood plasma or an increase in sodium or an increase in potassium. It causes an increased absorption of water. The water is going to follow by osmosis, and it's going to cause an increase in the excretion of K. So I have another video.
This little light of mine, I'm gonna let it shine.
What is aldosterone? I'm going to tell you everything that you need to know about aldosterone in this video. And if you want more nursing school tips and tricks and resources, be sure to subscribe and click the bell. Now let's do it. What is up, my friend? Christina here with NursingSchoolOfSuccess.com, and today in this video we are talking all about the hormone aldosterone. So aldosterone is a hormone that is released by the adrenal glands, and the adrenal glands sit on top of the kidneys. So sometimes you might hear that the kidneys release aldosterone. That's really only half true slash not really true at all. Aldosterone is really released by those adrenal glands, and those adrenal glands are on top of the kidneys. And aldosterone plays a huge role in balancing fluids and electrolytes in the body, particularly regulating fluid volume, sodium, and potassium levels. So there are 4 key things that I want you to know about aldosterone. Number 1, it is released if the blood pressure or fluid volume gets too low, or if there is some disease causing it to release when it's not supposed to. Number 2, it causes the kidneys to hold onto water. Number 3, it causes the kidneys to hold onto sodium. And number 4, it causes the kidneys to get rid of potassium. Now let's do some critical thinking around this so we can really understand what is happening with aldosterone. So when the blood volume in the body is low and the blood pressure is lower, aldosterone is stimulated to be released. And when aldosterone is released, it has those 3 main actions. It causes the kidneys to hold on to water, causes the kidneys to hold on to sodium too, and it causes the kidneys to get rid of potassium, like we said. So when aldosterone is released, the fluid and sodium levels are going to rise in the body, and the potassium level is going to drop. Does that all make sense? I hope it does. Because aldosterone tells the kidneys to hold on to more water and sodium and get rid of potassium. Now, let's talk about the flip side of all this. What do you think will happen when there is too much fluid volume in the body already? Aldosterone will be inhibited, yes, because aldosterone's job is to keep sodium and water inside the body. But when there's already too much fluid in the body, it doesn't need any more. So aldosterone should not be released. So make sure to remember those 4 key things about aldosterone. It is released if the blood pressure or fluid volume gets too low, or if there is a disease causing it to be released when it's not supposed to. It causes the kidneys to hold on to water, causes the kidneys to hold on to sodium, and it tells the kidneys to get rid of potassium. And that is the role of aldosterone in the body. Now, make sure that you print off the Med Surg checklist that I've got for you. It's gonna walk you through step by step how to study Med Surg in nursing school. With more Med Surg videos, cheat sheets, study guides, and care plans for you to help you succeed in nursing school. Thank you so much for watching this video, friend. Now go become the nurse that God created only you to be. And I'll see you right back here next time on the Nursing School Show. Take care.
Okay. All right, so that was aldosterone. And then we have ANF, or atrial natriuretic factor, or sometimes you'll see it as atrial natriuretic peptide. So ANF is a cardiac peptide hormone that is stored in the cells of the atria of our heart. It is released by certain cells in the heart in response to an increase that it senses inside the pressure of the atria. So when the pressure rises, these special cells release this cardiac peptide hormone. The atrial natriuretic factor is going to counteract, so work against the renin-angiotensin system by decreasing blood pressure, okay, and increasing respiration. So you guys need to know that. You are going to see this again, probably on a test. So you need to know how ANP works. And it works by decreasing your blood pressure and increasing your respirations. So Sophia, if you are still in the class, I need you to turn your camera on, because if you're not going to turn your camera on, then I have to remove you from the class. Thank you. So ANP is going to suppress what we call serum renin levels in the system. It's going to decrease aldosterone release from those adrenal glands. It's going to increase glomerular filtration, which increases our urine excretion, okay, of our sodium and our water. And it's going to reduce vascular resistance by causing vasodilation, so you can get more blood flow. And it reduces vascular volume and our blood pressure. So, do you guys like these videos? I think she's very helpful.
Waiters always look at me and think that I'm gonna have a little salad, maybe a soup, and that'll be the whole meal. And when I do my actual order,
many situations can elevate blood volume and pressure. In response to rising blood pressure, atrial cells in the heart will stretch, stimulating the secretion of atrial natriuretic peptide. ANP targets muscle cells in blood vessels and causes them to relax. This results in vasodilation and the lowering of blood pressure. Atrial natriuretic peptide also targets cells of the proximal convoluted tubule in the nephron of kidneys. There, it inhibits the retention of sodium ions, which reduces the retention of water. Less water returning to the blood causes blood pressure to return to normal. High levels of angiotensin II result from low blood pressure or low levels of sodium ions or high potassium ion blood concentration. These high levels stimulate the production of aldosterone from the zona glomerulosa cells of the adrenal cortex. Aldosterone binds to the principal cells of the collecting ducts of the nephron, where it promotes increased sodium, chlorine, and hydrogen carbonate reabsorption from urine, increased water retention and reabsorption back into the bloodstream, and increased potassium and hydrogen secretion. The conservation of sodium, chlorine, and hydrogen carbonate ions, as well as water, and the elimination of excessive potassium and hydrogen ions, results in an increase in blood volume and pressure.
All right, so that was your atrionatriuretic peptide or your atrionatriuretic factor, whatever you would like to call it. So why do we need electrolytes? So we need them to promote neuromuscular function. They help our muscles. We need it to help maintain the osmolality of our body fluid because our body fluid is made up of electrolytes. We need it to regulate our acid-base balance in our body, and we need it for the distribution of body fluids and electrolytes among the different compartments. So patients that we see that are at risk for imbalance of their electrolytes. So these are patients that have GI losses. So patients that are vomiting, patients that have diarrhea, patients that have, we're doing NG tube suctioning, or we're taking fluids like from a G tube or something like that, or if they have drains, patients that have fever because they're sweating, they're losing fluid, patients that are bleeding. Okay, their circulating volume is going to be lower. Patients that have edema, too much fluid. So all of those electrolytes are going to be washed down because we have all this fluid. Patients that have ascites in the belly. So that's your patients that are alcoholics or patients that have liver disease. Patients who are on diuretic therapy. So patients maybe congestive heart failure, we're giving them diuretics to help pull off all the fluid. Certain diets can cause us to be at risk for electrolyte imbalance, depending on what type of, if we have a lot of sodium intake in our diet, and then some psychosocial problems as well can cause issues. So we are going to talk about all of our electrolytes. The first one we're going to talk about is potassium. So the normal level of potassium is 3.5 to 5.3. You will see that when you go into the clinical setting, or if you work in a hospital now, these numbers will be a little bit different. Each facility has their own lab that has their own guidelines. So it might be 3.5 to 5.5 or 3.6 to 4.5, whatever. So, but the normal that I want you guys to know for testing and for CCBC is 3.5 to 5.3. So potassium is a major intracellular cation. So it's going to be inside our cells. So we said earlier that we talked about cations and anions. So cations, are they a positive charge or are they a negative charge?
Positive.
Positive.
Yes, very good. So there you have it. There's your cations. Sodium, potassium, calcium, hydrogen, and magnesium. They are positive. So, all right. So intracellular cation. What does potassium do? It helps maintain our cells' electrical neutrality and our osmolality. It helps neuromuscular transmission of those nerve impulses through our body. It makes our skeletal and our cardiac muscle contract, and it also has to deal with the electrical conductivity in our skeletal and our cardiac muscle. And potassium also affects our acid-base balance in relationship to hydrogen ions. So it's a very, very, very important electrolyte. Any small change, whether it be an increase or a decrease, we're going to talk about, you'll see major signs and symptoms, and your patients are at risk, I mean, life or death risk to having with these deficiencies in potassium and all of our electrolytes. So potassium is absorbed in our GI tract. We can get it through our diet. Never really can we get, if we're at a loss, if we have low potassium in the hospital, it would be hard for us to increase our potassium levels in the amount of time that we would need to see an increase while we're in the hospital. So normally we will give medications to bring them up, but in general, we can get them in our diet. So we find them in bananas are high in potassium, orange juice, broccoli. We can see them in sardines. You guys need to know the diets for these different, how we can find these different electrolytes, because you are going to be tested about how we can make sure our patients are compliant with bringing these electrolytes into their diet. So you guys need to know that. We do secrete our potassium through our GI system. So if you have a patient that has severe diarrhea, what would you expect their potassium level to be? Do you think it would be high, or do you think it would be low?
Low.
Low, very good, because they're losing all of their K, very good. And then the potassium helps balance that potassium sodium pump, right? You guys probably remember that from biology. So aldosterone causes the retention of sodium in the distal tubules and the excretion of K. And ADH, that antidiuretic hormone, is going to decrease the amount of sodium in our body. And whenever our sodium levels go down, then our potassium levels are going to go up. So hypokalemia is a serum potassium less than 3.5 milliequivalents per liter. It is an insufficient amount of potassium in the extracellular fluid. So how do we get hypokalemia? Well, maybe we don't have the proper intake in our diet. We are not taking in enough potassium. Maybe we are we have an increased utilization. Our body is using too much. We could have a certain metabolic disorder to where our levels are not appropriate. We could have alkalosis, which we are going to talk about, I think, in week 3 or week 2 next week. We could have excessive potassium loss from vomiting, having diarrhea. If our patients have an NG tube and we're doing gastric suctioning, we could be pulling off too much, so their potassium could be lost. And then, of course, if we give them diuretics, depending on what type of diuretic, not all of them are potassium sparing, so they lose everything when we give them diuretics. So they are at loss for developing low potassium, hypokalemia. Chewing tobacco, alcohol, and licorice abuse can cause hypokalemia. And then renal loss, renal disease can also cause hypokalemia. Our kidneys help maintain a potassium balance by either eliminating potassium or conserving and holding onto it. So if our kidneys are not working properly, then we could have hypokalemia, when you guys can probably also guess that we could also have hyperkalemia if our kidneys are holding on to too much potassium. So this is just a cute little picture that I found, which shows you a little mnemonic to help remember potassium deficits. So it says, I am a sick Walt. So if you have hypokalemia, you can develop alkalosis. So alkalosis is a condition in which all of our body fluids have an excess base. After we have our lecture next week, that will make more sense to you. Hypokalemia contributes to what we have called a buildup of alkali in the body that results in the alkalosis. Hypokalemic alkalosis is caused by the kidney's response to an extreme lack or a loss of potassium. And like we said earlier, if it's left untreated, it can be fatal. So your patients will present with shallow respirations. They might be irritable. They may be confused and appear to be drowsy. They're going to be very weak and they're going to have fatigue. Remember, it affects the cardiac muscles and their muscles. So if they don't have enough of it, their muscles can't work right. So they're going to have that weakness. They're going to have that confusion and fatigue. The heart is also a muscle. So that's where we're going to see arrhythmias. The heart might not pump like it's supposed to. It might pump too fast. It might pump too slow. It might have an irregular rhythm. Okay, so as soon as you think potassium, you should think arrhythmias, and your patients are going to need to be on heart monitors. They might be lethargic. They can present with a thready pulse, and then their intestinal mobility is going to be decreased. Nausea, vomiting, you might see, and they might present with an ileus. Okay, so this is a nice little mnemonic to help you remember. We also have medications that cause hypokalemia. So corticosteroids such as prednisone, they work in the body to cause renal retention of sodium and fluid, which causes a potassium loss. Because remember, if sodium goes one way, then potassium goes the other. A byproduct of the sodium retention is renal potassium loss. Cisplatin is a chemotherapy drug, which causes hypokalemia. So you would see that in your cancer patients. And adrenergic medications such as albuterol or epinephrine and theophylline. These are medications that we give to our COPD patients. They have a side effect of hypokalemia. Diuretics, so the thiazides and the furosemides. When our patients have too much fluid, we give them this pill to help them pee and get out that fluid. Well, it also takes all the electrolytes with it. These are not potassium sparing, so then the patients present with low potassium. So insulin causes a shift of potassium into the cells. When the insulin takes the glucose in, it also takes the potassium into the cells as well. And then laxatives in excess. So people that take too many, if they abuse them, potassium obviously is going to be excreted in the stool, and they're going to present with hypokalemia. So when we're looking at the renal assessment for hypokalemia, these patients are going to have a decreased ability to be able to concentrate urine. So if they cannot concentrate their urine, what are they going to be doing? They're going to be going to the bathroom all the time, right? So that's what we call polyuria. And then they're going to have a decreased specific gravity, which is a test. It's a lab that we look at. It's called decreased specific gravity. Nursing interventions for your patients that have hypokalemia. We're going to want to monitor their eyes and nose, right? We are going to want to assess any ECG changes. So you're going to want to have them on that heart monitor. You're going to be checking their heart rate. You're going to be watching their heart rhythm. Any pattern? Is it irregular? Is it regular? Do they have PVCs? Anything like that. We're going to be watching their serum electrolyte levels through labs. Normally they'll pull labs every single morning, especially if they're on diuretic therapy, so they can decide what kind of replacements they have to do the next day. If they need it, we're going to infuse parental K as ordered. We're going to make sure that we monitor them through an EKG. Whenever replacing the potassium, we'd like to have them on a monitor. We want to educate our patients about foods that are high in potassium. So we want them to have a high fiber diet. We want to increase their fluids to prevent constipation. So foods that we can tell them to eat. It's going to be raisins, bananas, apricots, oranges, avocados, beans, beef, potatoes, tomatoes, cantaloupe, and spinach, all high in potassium. And we want to teach our patients to avoid black licorice because that causes hypokalemia. We're going to want to make sure that we assess those vital signs, right? Blood pressure, respiratory rate. We said that some patients will present with shallow respirations. So we're going to watch the depth and their pattern. We never, ever, ever give potassium as IV push. It can be fatal to your patient. So if you ever get an IV, if you ever get an order for potassium as an IV push, you cannot give it because it can kill the patient. And then we want to prevent gastric irritation of K orally by administering it with at least 4 ounces of water. So sometimes in the hospital, they'll give you potassium pills to give. You cannot crush them, you cannot break them, and if they come in capsules, which I've never seen, I've only ever seen the tablets. So if you have a patient that can't swallow pills, if they have a G-tube or something like that, you would have to make sure you order the liquid potassium for them because you cannot cut the tablets in half or break them. And you should tell your patients if it bothers their stomach that they can take it after they have a meal or with their meals to help prevent GI upset. So medication manage, what would we give? Well, we would give potassium chloride. So it's called different things in the hospital: K-Lite, K-Tab, Slow K, K-Dur, Micro K. Every hospital has their own type of medication they like to use. We replace with 20 to 100 milliequivalents per day, PO usually, or we give aliquots. We can give the medication IV, but it does cause burning around the infusion site. I've never had a patient that I've given vitamin K to where it has not burned the arm. It's very, very hard on the veins. So what you have to do sometimes is you may have to, if it's ordered for 100 cc's, 100 mLs per hour, you might have to decrease it. What I always do, if they don't have any kind of fluid overload, or if they do, I just have to ask the doctor. I will run fluids with the vitamin K, and it kind of like dilutes it out and it keeps it from burning. But you have to get permission from the doctor to do that. Some side effects from the vitamin K is abdominal pain, diarrhea, nausea, and then of course arrhythmias, because whenever we replace potassium, right, we said just like with fluids, we can cause the opposite problem. So we could cause hyperkalemia. So we want to watch for those arrhythmias. So now we're going to talk about hyperkalemia. So this is high potassium levels greater than 5 milliequivalents. So what are some causes? So excess potassium intake. It could be that we're giving it to them through an IV, or it could be in their foods. Some of the things that come to my mind are a lot of the heart patients will use no salt because of their blood pressure issues and their heart problems. Well, no salt is actually all potassium. So very commonly you will see patients with CHF have these high potassium levels because they are using this no salt all the time. Or we could be giving them IV fluids that have potassium in it. We might have kidney problems, and if our kidneys aren't working properly, we might be retaining potassium. We could have excessive release of potassium if we have the lysis of cells in our body. We could have excessive potassium from PO pills or IV infusion, and then certain medications can cause it. So heparin, some of our ACE inhibitors, NSAIDs, and then our potassium-sparing diuretics can also cause it. So hyperkalemia is an increase in our cell excitability, right? Because hypokalemia was a decrease in cell excitability. So hyper, too much, our cells are going to be hyper. The myocardium, which is our heart, is the most excitable tissue. That's why we're watching for those arrhythmias. Very rare in people with normal functioning kidneys. The nerve conduction as well as muscle contractility is going to be affected. We're going to see skeletal muscle weakness and paralysis that could occur. And we are going to see cardiac irregularities, and cardiac arrest can occur if we don't correct these levels. So these patients have to be on a heart monitor if they have high potassium. So here's another little mnemonic for you. So your patients are going to present with muscle twitching. They can have cramps, paresthesias. Paresthesias are numbness and tingling. They might be irritable. They might be anxious. They might state that they feel like some kind of like impending doom. They can't sense what's wrong, but they don't feel right. They can have a decrease in their blood pressure. You're going to see some EKG changes. You're going to have them on that heart monitor. So EKG changes that you might see down here at the very bottom. Let me make this bigger so you can see. This is, and we'll know more about this next semester, this is what we see on an EKG. So this little hump here is your P wave. If you have a patient that has hyperkalemia, you might not have that little bump there. It might be flat. This little area right here, we call this the QRS. This could be wider. Normally we want it to be a certain width. But in these cases of hyperkalemia, it gets very wide. And then we have here what we call a T wave, which is the end of our heart cycle. sometimes it gets extremely elevated, and we call that a peaked T wave, or we can have what we call an ST depression, where it comes down. So that's what we mean by EKG changes. We could see dysrhythmia, so you could have an irregular rhythm. The patient might complain of abdominal cramping, and they might have diarrhea. So when you think of hypokalemia, you can think of murder. So M is for muscle cramps, U is for urine abnormalities, R is for respiratory distress, D is for decreased cardiac contractility, E is for EKG changes, and R is for reflexes. So medications can also cause hyperkalemia. So we have our angiotensin converting enzyme inhibitors. They can cause high potassium, certain antibiotics. We have certain chemotherapy drugs that cause it, digoxin and heparin, and our NSAIDs will cause it. Obviously potassium, right, if we take too much. And then our diuretics that pull off every thing in our fluids except for our potassium. So the potassium can build up. All right, so these again are the effects of hyperkalemia on that electrocardiogram, or we call it an ECG. So we can see that ST depression. This would be an example of an ST depression. We can see this tented or tall T wave right here. This is what a normal one would look like. You can see how tall it is. Sometimes they'll be flattened, so they don't look normal. They're a little flat. We can see this prolonged PR interval. So this is what a normal PR interval looks like, but it can get longer. And then this QRS. So this is a normal. It can become wider. Okay. So nursing interventions for hyperkalemia. So we're going to restrict that potassium intake. We're going to instruct on foods that are high in potassium that they should avoid. And we're going to teach them about avoiding those salt, whoops, that's misspelled, those salt substitutes, like no salt, because they're all potassium. We're going to put that patient on a telemetry monitor, a heart monitor. We're going to be monitoring for EKG changes. So when you think hyperkalemia, you should automatically think heart and EKG changes. We want to promote potassium excretion. We can use cation exchange resins called K-exalate. We can give them K-exalate. It will help them to have bowel movements that will excrete the potassium with it. We can infuse glucose and insulin, because remember, the movement of K into the cells is increased in the presence of insulin. So insulin increases the activity of that potassium sodium pump, and it can it's going to carry that potassium into the cell with the insulin. And then you could also administer potassium wasting diuretics, but then you have to watch all the electrolytes to make sure that you're not causing other levels to decrease as well. So for mild cases, normally we use loop diuretics. That's usually the first drug of choice. Sometimes we give sodium bicarb. Sodium bicarb helps decrease our potassium by shifting potassium into the cells on a temporary basis. Takes a little longer to work, 15 to 30 minutes, and it only lasts for about 1 to 3 hours. We could also give calcium gluconate, also a very short-lived response, but we can use it. We want to administer, we can minimize the amount of potassium that's released from our body. We talked about the calcium gluconate. This helps, calcium will help balance out the change in the membrane potential that is seen when the potassium leaves. So when you'll see that sometimes we give the potassium and the calcium gluconate together, because when we pull that potassium out, it can cause a change in that membrane. So the calcium helps balance out that change. Sometimes patients will have to go into dialysis. If their kidneys aren't working, then we have to do it for them. And then again, those loop diuretics for mild cases. So we can give sodium polystyrene sulfonate, which is also K-exylate. It works in the body to exchange sodium ions for potassium ions. It binds with potassium. It's then eliminated in the feces. Side effects might be constipation. We could see fecal impaction and hypokalemia because we might remove too much, right? It's always that balancing act. PO is how we give it. It's usually 15 grams at a time, 1 to 4 times a day. Sometimes we can give it rectally in a retention enema. If we do that, we have to give a cleansing enema first, and then we can give this retention enema 25 to 100 grams per enema. The doctor always decides that, of course, the strength. And then if you have not lowered your patient's potassium as expected, what are some things that we should consider? So the doctor has ordered some medication. We're trying to lower the potassium. Maybe we're giving them diuretics, but the levels still aren't coming down. Maybe we're giving them K-exylate, but it's still not bringing those levels down. So what should we think? We want to think about their renal functioning. Is their renal status worsening? Is their creatinine rising? Their bun going up? Their kidneys are not working properly? Is the patient taking a medication that could be raising that potassium level? So then we need to go in and look at all the medications that the patient's taking. And then sometimes we want to think, is the patient taking an antacid? So sometimes patients take antacids for acid reflux or indigestion, something like that. Those contain magnesium or calcium, and they can interfere with ion exchange resins in the body and cause potassium issues. All right, so now we're going to talk about sodium. So sodium is a major extracellular cation, right? Positively charged electrolyte outside of the cell, extracellular. Normal range, 135 to 145. So you guys need to know all the normal ranges for all of your electrolytes, okay? Hyponatremia is going to be less than 135. Hypernatremia is going to be greater than 145. Some sodium is found in our intracellular fluid, but it's not measurable. But there is a very small amount there. How do we get sodium in our body? So we take it in through our diet, right? Processed foods are filled with sodium. The minimum requirement is 2 grams daily. 1 teaspoon of salt has about 2,325 milligrams of sodium. Our minimum requirement a day is 2,000 milligrams, right? So a teaspoon of salt has a lot. It's found abundantly in a lot of foods. What is the function of sodium? So we need sodium to facilitate impulse transmission in our nerves and our muscle fibers by participating in that sodium-potassium pump. Sodium influences the levels of potassium and chloride. So sodium is usually paired with chloride, and it's conserved and excreted together. It assists in maintaining acid-base balance, as in sodium bicarbonate, and it regulates volume and osmolality of the extracellular fluid, and it regulates body fluid because wherever salt goes, water goes, right? So the kidneys naturally work to help balance the amount of sodium that are stored in our body. When sodium levels are low, our kidneys will say, hey, we don't have enough sodium. It's going to hold on to the sodium. When our sodium levels are high, the kidneys will do the opposite and it will excrete the excess in our urine. When the kidneys can't eliminate enough sodium, the sodium accumulates in the bloodstream. Sodium is like a magnet for water, just like the albumin. The increased sodium attracts to the water and the blood volume starts to increase, which in turn is going to increase the workload of our heart, right? And contribute to high blood pressure. So this is why we tell patients who have high blood pressure that they need to be on low salt diets, right? Sodium is also excreted through the GI tract and through the skin in sweat. So whenever you think about sodium, you should also think about water. The two are very closely related. So an increase in sodium is going to be an increase in that extracellular fluid concentration. A decrease in sodium is going to be a decrease in that extracellular fluid concentration. So sodium is lost through our skin, through sweating, fevers, GI, right? We pee, and our GU system, pee and feces, we have a small amount of water that comes out in our feces. We have aldosterone, that aldosterone system, remember, it helps increase absorption. We have decreased extracellular fluid, is going to reduce the ECF osmolality. It's regulated, our sodium is regulated by that renin, angiotensin, aldosterone system that we talked about earlier, and sodium concentrations affected by our salt and our water intake. We have too much water intake, it's gonna diminish those sodium concentrations, right? And if we don't have enough, if we are dehydrated, we're gonna have higher amounts of sodium concentration. So hyponatremia is a decrease in sodium. So we can cause hyponatremia because patients have prolonged diuretic therapy. So they have a lot of fluid. We are giving them, we're diuresing them every day, giving them a diuretic to help pull that fluid off while we're pulling all the electrolytes out. Excessive burns. So whenever a patient has burns across their body, it's going to cause a large loss of extracellular fluid. So if our sodium is in our extracellular fluid and we have burns, we're going to lose a lot of that sodium. Patients that have excessive diaphoresis, so sweating, prolonged vomiting, diarrhea, NG suctioning, draining fistulas, excessive ingestion of plain water, so compulsive water drinking. So I don't know if you guys are old enough to remember, there was a contest many years back to win a car. They did it on the radio show, and it was whoever could take in as much water as the fastest. And these people were doing this, and they drank and drank and drank as much water as they could. Well, one of the women died because she took in too much water. She diluted all of her electrolytes, her sodium, she died. So taking in too much water can deplete your sodium. If you have renal disease, obviously your kidneys aren't functioning. You can have both issues, hypo and hyper. And then if we give excess IV fluids to our patients, sometimes we do it. We don't turn off those fluids. We give them too much, too fast. It can cause hyponatremia. So if we give excessive IV administration of water or D5W, that compulsive water drinking, if we have inadequate intake of water and absorption, if they have adrenal insufficiency, so they have low aldosterone, right? That's going to make sense. And then if they have inappropriate ADH, so this is SAIDH, where this is a syndrome where water is retained and diluted, hyponatremia occurs. We're going to talk a little bit more about that. So this is the decrease in sodium causes the fluid to move by osmosis from the less concentrated ECF compartment into the ICF, the intracellular fluid space. The shift of fluid is going to lead to the swelling of cells, including the blood cells. So this is going to be, I listed your hypotonic, your isotonic, and your hypotonic, your hypertonic, so you can see how the fluid shifts. So with hypotonic, make this bigger, the cells inflate and they burst. Water is transported into the cell, okay? The solute concentration inside the cell is going to be higher. The cells are going to swell up because all of the water is coming into the cells. With isotonic, this is the amount of water that is transported into the cell is going to equal the amount of water transported out of the cell. So it's going to be equal. All the water outside of these cells, along with the water inside the cells, is going to be equal. So nothing's going to change. Then we have hypertonic. The cells are going to shrink. All the water is transported from inside the cell out. So it's a solute concentration inside the cell is lower than the outside the cell. Okay, so those cells are going to shrink. So hyponatremia, low sodium, salt loss is how you can think of it for signs and symptoms. So your patient for S, they're going to present with stupor, confusion, coma even. If it's critically low, anorexia. They're going to have nausea and vomiting. They're going to be lethargic. Their tendon reflexes are going to be decreased. Okay, I want you guys to remember that. Their tendon reflexes are going to be decreased. They're going to have muscle weakness. Their muscles are going to be limp. Their blood pressure, they're going to present with orthostatic hypotension. You guys need to remember what that was, okay? It's when you change position from lying to sitting to standing, and you see that drop in that systolic and diastolic number. They might have seizures, they might complain of headaches, and they might have stomach cramping. So you are going to make sure that you are monitoring for alterations in level of consciousness. This is something that we see all the time with our old people. Our old people come in, they're dehydrated, and they are confused. It's one of the first things we think about with older people when they have a change. We're going to think UTI, or they're dehydrated, or they have low sodium. So what are some drugs that affect hyponatremia? So anticonvulsants, carbamazepine, that can cause it. Anti-diabetic medicines can cause it. Some of our anti-neoplastic, our chemotherapy agents can cause it. Vincristine, cyclophosphamide can cause it. Different antipsychotics, so flufenazine, leorizidine, and thiazine can cause it. Certain diuretics. And then we have certain sedatives, so barbiturates and morphine can also cause hyponatremia. So what are we going to do to help our patients? We're going to aid in treatment by restoring that sodium level, right? We want to bring those sodium levels back up. So we're going to restrict their water intake. They might be on a fluid restriction to allow the sodium in the water to balance out naturally. We are going to administer hypertonic IV solutions. So we're going to force that water to leave the intracellular fluid and cause cellular shrinkage. So the fluids that we can give are 5% dextrose, 0.5% sodium chloride, or we also say half normal saline. We say that as sometimes you'll hear them in the clinical setting. And sometimes we can give D5 and 0.9% normal saline. You guys, for testing purposes, are going to need to know what type of fluids to give your patients to help restore their electrolyte levels, okay? We are going to encourage foods that are high in salt, right? Because their levels now are low. We're going to be measuring that intake and output every day, and we're going to measure daily weights. Water and sodium go hand in hand, so we want to know if they're gaining weight and what their output and intake is. So we're going to weigh that patient daily, and then we can replace sodium in 3 forms. We can give sodium chloride, we can give sodium acetate, and we can give sodium phosphate. It just depends on what the physician orders. So I said a couple slides back where we're going to talk about the syndrome of inappropriate antidiuretic hormone, SIADH. So this is caused by a release of ADH without regard for serum osmolality. So we said when there was a disturbance in our serum osmolality, or our plasma volume changed, or our blood volume changed, our blood pressure changed, that our body would release this ADH. Well, with this syndrome, it just releases without any regard for those issues. So we might not have any issues with serum osmolality, plasma, or blood pressure. It's just going to keep releasing. So what happens is it's going to result in excessive water retention. So the body's going to hold on to water, and it's going to wash out all that sodium. So the patient's going to be left with hyponatremia. When will you see this? Sometimes in patients that have multi-system failure, so kidney, liver failure. You see it sometimes on oncology patients, sometimes post-operative patients, some patients that have brain injury. It's water that is typically excreted is going to be reabsorbed back into our circulation. So you guys need to understand SIADH. You will be seeing that on your test. So here's a little breakdown again. The body secretes too much ADH, antidiuretic hormone. Antidiuretic hormone increases the permeability of the renal tubes in the kidney. That increased permeability then increases water retention, right? The body's going to hold onto that water. It's going to increase our extracellular fluid volume and cause cerebral edema. That increased volume is going to lead to reduced plasma osmolality. So we're going to have so much water that the osmolality is going to be diluted. It's going to cause dilutional hyponatremia, diminished aldosterone secretion, and then it's going to elevate our GFR, which is our glomerular filtration rate. All of these factors cause increased sodium excretion and a shift of fluid into the cells. So your patients are going to be thirsty. They're not going to be able to get enough to drink. They might have dyspnea on exertion. Why do you think they're going to be dyspneic when they're walking around? Shay, what do you think? Why do you think your patients are going to be dyspneic? I think your mute is on. Is she still there? All right, Danielle, what do you think? Why do you think your patient is going to be have dyspnea on exertion, which means they get shortness of breath when they're doing any kind of activity?
I know like different factors, like if they have like a respiratory condition will take effect, but it could also be
It's okay if you don't know. I just want to get you guys thinking. So these patients have too much water. They have water everywhere, right? It's coming everywhere in their body. It's just piling up. So it's also piling up around the lungs and the heart, right? So too much fluid. So when they walk, they're going to get out of breath because they have all that fluid.
Like their weight then, like the increase their weight, making it more difficult.
Yes, all of it together.
Maybe not.
Exactly. Yep. Very good. So that's why they're going to be have shortness of breath when they're doing any type of activity, walking, doing anything. They might be vomiting. They might have abdominal cramps. You're going to see confusion. They might not know where they are. They can be very lethargic. And then, of course, we're going to see hyponatremia in their labs. You guys need to know that, okay? SIADH. So what is the patient going to look like? We're going to see decreased urine output with concentrated urine, right? Because we are holding on to that. We're holding on to that water, so we're not getting it out. We're not going to the bathroom. Decreased urine output, more concentrated urine, altered level of consciousness, fatigue, headache, diarrhea, anorexia, seizures. Edema with SIADH, you might not see the edema with the fluid excess because the water is going to shift into the cells, okay? So you might not see the edema, but you will see the weight gain. You're going to see that elevated blood pressure, that circulating volume. They're going to have decreased salivation, and then they're going to have decreased skin turgor, okay? So hypernatremia. So now we have too much sodium. So this is excess sodium in the blood. So our water loss in excess of sodium. So we're holding on to sodium, we're losing too much water. So this is going to be from excess salt intake without sufficient water intake. This happens sometimes if we have severe watery stools, if we have severe insensible water loss, high fevers, burns, if we're doing osmotic diuresis of our patients. Sometimes we see it with diabetes insipidus, when there's fluid shifts in the body. And then in certain conditions, water will shift out of the intracellular fluid into the extracellular fluid to balance the excess extracellular fluid sodium. This is going to cause those cells to shrink as they lose water volume. So excessive administration of IV fluids that contain sodium can cause it, and hypertonic fluids can cause hypernatremia as well. So for hypernatremia, we are going to think fried salt. So flushed skin and fever, low-grade fever, restless, anxious, irritable, or confused, increased blood pressure and fluid retention, edema, so peripheral end pitting, decreased urine output, and dry mouth, skin flushed. They might be agitated, have a low-grade fever and lethargy, and they are going to be very, very thirsty. So what are some nursing interventions that we want to do? Well, we want to aid in the treatment by reducing the serum sodium level. We want to bring that sodium level back to normal. We're going to measure and record weights every day. We're going to assess their mentation, right? Because back here we said that they can be lethargic, agitated, and confused. So we're going to watch that mentation and orient them to their environment, right? Administer hypotonic parental solutions with caution to prevent fluid overload. Because again, it's always a balancing act, right? Sometimes we fix something and we cause something else. We're going to provide oral hygiene every 2 to 4 hours for these patients because they're going to have a dry mouth. Remember, we said they're really thirsty. So make sure you are providing good oral hygiene every 2 to 4 hours. Encourage increased fluid intake as appropriate, and then we're going to decrease that salt intake, right? So all the opposite that we did for the last scenario, we're going to do different for this one. Okay, so that was sodium. Now we're going to talk about calcium. So calcium is a major cation, positively charged. Normal levels are 9 to 11. Our ionized calcium is 4.4 to 5.4. So the difference between ionized calcium and serum calcium, so serum calcium is this normal level here that I have, the 9 to 11. So the main difference is that ionized calcium is the amount of free, what we call free calcium in the blood, whereas serum calcium is the total amount of calcium that's present in the blood, okay? So ionized is the free calcium, serum calcium is the total. Calcium is regulated very closely with magnesium and phosphorus. Most of our calcium is found in our bones and our teeth. A very small percentage, 1%, is found in the blood. Our daily requirement is 800 to 1200 milligrams per day. Nearly half of all calcium is bound to the protein albumin, and protein abnormalities can affect calcium levels. So if you have a patient that has albumin issues, they will probably have calcium issues as well. So calcium contributes to bone and teeth rigidity and strength. It's partially responsible for maintaining our cell membrane structure and our function. It's required for neuromuscular conduction by its participation in, it works with the sodium-potassium pump. We do need calcium for our cardiac contraction. It's required to secrete different hormones in the body. Calcium affects the contraction of our cardiac muscle, our smooth muscle, and our skeletal muscle, and it also plays a role in blood clotting. And patients with blood clotting issues are at risk for developing calcium issues as well. So calcium is absorbed in the GI tract. Excretion is through the renal system, and excesses can result in stones, so kidney stones. I'm sure you guys have heard of that. Calcium operates on a feedback mechanism. So when serum calcium levels are low, our parathyroid gland is going to secrete PTH, which draws calcium from our bones and promotes the transfer of calcium along with phosphorus. It takes phosphorus with it into our plasma, ultimately increasing our calcium levels. When high serum calcium levels are detected, the PTH secretion is going to be inhibited. PTH also promotes the kidneys to reabsorb calcium and tells the intestine to absorb the mineral. Phosphorus is excreted at the same time. Dietary sources, so obviously our dairy products, milks, cheese, eggs, green leafy vegetables, legumes, molasses, whole grain, nuts. These are all good dietary sources of calcium. So if our serum phosphorus levels, remember I said calcium and phosphorus kind of work together. If our serum phosphorus levels are higher than normal, then calcium will bind with the phosphorus. The calcium phosphate forms and can be detrimental by causing calcifications in our eyes and our blood vessels and our cardiac conduction. Calcitonin, which is a thyroid hormone, moves calcium from our plasma to the bone whenever serum levels increase. And vitamin D is required for the absorption of calcium in our intestines. It promotes calcium absorption through the intestines, calcium resorption from our bone, and kidney resorption of calcium. All of these help to increase the serum calcium level. So vitamin D is not something that our body makes. We have to get this through food or from being outside in the sunlight. It's not something that our body makes. So calcitonin is that hormone produced in the thyroid gland. It acts as an agonist to PTH, helps regulate the calcium levels. When calcium levels are too high, the thyroid gland is going to jump in and release calcitonin. High levels of this hormone inhibit that bone resorption, which then causes a decrease in serum calcium level. So calcium and phosphorus have that inverse relationship in the body. When calcium levels go up, phosphorus levels go down. When calcium levels go down, phosphorus levels go up. So you guys need to know that, okay? You need to know how these feedback systems work. So we're going to talk about hypokalemia, which is low calcium, so less than 8.8 serum or 4.4 ionized. So what causes hypokalemia? Well, inadequate intake, or if we have an absorption problem with calcium. So anorexia, acute or chronic renal failure, inadequate exposure to ultraviolet light, remember, because it converts vitamin D to an active form in our GI tract. Excessive excretion, so again, those large doses of Lasix when we're diuresing patients. And then if we have low PTH level, right, it's going to reduce calcium absorption. So hypoparathyroidism is going to reduce levels of PTH, which is going to cause low calcium. If we have low albumin levels, it can also cause low calcium. If you have renal failure, it's going to cause hyperphosphatemia, right? It's going to increase our phosphorus if you have renal failure. So if our phosphorus is high, our calcium is going to be low. So in kidney failure patients on dialysis, they chronically have these high phosphorus levels and low calcium. It's an ongoing issue. Patients that have a thyroidectomy or a parathyroidectomy, you're going to expect to see low calcium. You guys need to know that. Okay, if you have a patient that has had their thyroid out, a thyroidectomy or a parathyroidectomy, the parathyroid hormone cannot help regulate the calcium. So your calcium levels are going to be low. And then if you have any burns or infections, that's an important slide. You guys need to know that. So hypokalemia, signs and symptoms, convulsions, arrhythmias in the heart, tetania, stridor, and spasm, so CATS. Muscles are going to cramp in the arms and legs. You're going to have muscle spasms, cardiac dysrhythmias, hyperactive deep tendon reflexes. Okay, this is an important slide. You guys need to know these signs and symptoms. Hyperactive deep tendon reflexes, paresthesias of the extremities, numbness and tingling. They might be confused. They might be moody. They might be anxious. Hypokalemia and tetany and seizures. You might have a positive, I don't even know how to say this. I know I always say it wrong. Chavostics and a Troches sign. So the chavostics is when you tap the patient's facial nerve just adjacent to their ear, and you're going to see facial twitching or a brief contraction of the patient's upper lip, their nose, or the side of their face. That's going to be a positive chavostic sign. The Troches is when you put a blood pressure cuff on them and you inflate it. After 1 to 4 minutes, you're going to see the patient's thumb adduct, their wrist will flex, and their metacarpophalangeal joints will flex, and then their interphalangeal joints with their fingers together will extend. This is going to indicate, this is going to be a positive sign of tetany, which is a major sign of hypokalemia. So there is, it's in your book. You guys can look it up. So you guys should know those signs. We are going to have easy bruising and petechiae on the skin, excessive bleeding when you are cut. Remember, we said it's going to affect that blood clotting. Patients with blood clotting issues have calcium issues, and it's going to cause prolonged bleeding time. So the blood's not going to clot like it normally should. So this is the Troches positive sign, and this is the chavostics, however you say that. I know I'm saying it wrong. Sign on the right. Okay, and there's more about that in your book. So what are some drugs that affect hypokalemia? So calcitonin helps lower blood calcium levels by suppressing the osteoclast activity in the bones, and it increases the amount of calcium secreted in the urine, thus causing low calcium, hypokalemia. Certain anticonvulsants, those loop diuretics, right? We're pulling all the fluid and electrolytes off. Corticosteroids can cause low calcium. And then drugs that lower magnesium levels, such as cisplatin, which is a chemotherapy drug, and gentamicin, which is an antibiotic. So lower magnesium levels affect the function of our parathyroid gland and decrease in calcium resorption from the kidneys and GI tracts. Okay. So nursing interventions, we're going to do cardiac monitoring. We're going to put them on that telemetry monitor. We want to monitor their heart. They're going to be on seizure precautions. So seizure precautions are different for each hospital. Usually you're going to line the bedside with covers so that, or get some type of seizure protection for the side rail. So if they have a seizure, they don't bump into each side of the side rail and get a head injury. You're going to want to have suction in the room. Whatever your hospital policy requires. You're going to give oral or IV administration of calcium gluconate to help bring the calcium levels up. When we give it in IV, it has to be in a large vein because it can be very caustic to the veins, and infiltration could cause sloughing. It does potentiate the action of digitalis, which can cause cardiac arrest. You do not want to add to IVs with bicarbonate or phosphorus. You want to run it by itself, and then you want to maintain a relative quiet environment, because remember, we said that our patients are going to be moody, they're going to be anxious, they're going to be, have muscle spasm, so they really need to have a nice quiet environment. So the medication that we can give calcium gluconate. We can give calcium carbonate, also known as Tums, over the counter. So if we're giving PO, they're going to get 1 to 2 grams a day. Side effects, again, cardiac arrest, arrhythmias, and constipation. So we're going to take, I guess we'll take a 10-minute break, and then we will pick up in 10 minutes with hyperkalemia. Okay? So 8:20, come back at 8:30. Noodle, you got a big plate. Oh my goodness. Cool, right? All right, thank you. All right, so hypercalcemia, too much calcium in the blood, higher than 10 milligrams serum and 5.4 milligrams ionized. Why do we get hypercalcemia? Well, maybe we're taking too much in. Maybe we're using certain calcium supplements, certain medications such as antacid or phosphate binding gels. Certain metabolic conditions can cause it. If a patient has hyperparathyroidism, that's making too much calcium. If you have renal tubule disorders, if you have low phosphorus, remember we said that if phosphorus goes one way, calcium goes the other. So if your patient has low phosphorus, they're going to have high calcium. Certain bone disorders or cancers such as Paget's disease or bone mets. So Paget's disease is a chronic condition that interferes with your body's ability to like remodel your body's bone. And then cancer. So cancers are the second most common cause of hypercalcemia. Cancer causes bone destruction as those malignant cells start to invade the bone. And if there's metastatic disease, and it releases hormones that are very similar to that PTH, which causes an increase in those serum calcium levels. And then immobility. We know that when our patients don't move, this is also going to alter their bone metabolism. So hypercalcemia, bone pain, more arrhythmias. We're going to be watching that heart, cardiac arrest, kidney stones, muscle weakness, and excessive urination. Vitamin A overdose can also lead to increased bone resorption of calcium. You have your lithium, which we take for certain mental health disorders, decreases your excretion of calcium in the kidneys. So those patients tend to have higher calcium levels. We have the thiazide diuretics, which decrease the excretion of calcium by the kidneys. Certain calcium preparations, and then we said them antacids. So we give patients Tums to bring their calcium levels up. Well, sometimes they take too many and then they have hypercalcemia. And then of course, vitamin D. So nursing interventions, we want to be able to eliminate the calcium excess. So we are going to give loop diuretics to pull off the calcium. We're going to give IV normal saline, which is 0.9% to foster diuresis. Because what goes in has to come out, right? Calcitonin to lower the serum calcium levels. It's going to lower calcium levels by suppressing that osteoclast activity in the bones, and it's going to increase the amount of calcium secreted in the urine. We're going to monitor their electrolyte status, and if the patient is asymptomatic, we're going to treat the underlying cause. So medications that we can give calcitonin. We can give it IM, so intramuscularly, subcutaneously, and we could give it sometimes IV. So side effects would be nausea, vomiting, injection site reactions, maybe facial flushing. Intranasal, we can give it through the nose for postmenopausal osteoporosis. Magnesium. Magnesium is the second most abundant cation in the intracellular fluid. Normal ranges are 1.3 to 2.1. Intake is through the diet, usually 300 to 350 milligrams daily. Sorry, that's misspelled. And excretion is through the kidneys. So if you have kidney issues, guess what you're going to have problems with? Your magnesium. Magnesium is found in bone cells and specialized cells of the heart, our liver, and our skeletal muscles. It is involved in the transmission of nerve impulses and muscular excitability. It makes the production of parathyroid hormone possible. It activates several enzymes systems, including the functioning of our B vitamins, our potassium, and our calcium. It contributes to vasodilation, and through this effect, it changes our blood pressure and our cardiac output. If we change our vasodilation, right, if we make our vasculature wider, more blood can get through, our blood pressure is going to increase, and so will our cardiac output because we're getting more blood in. It facilitates sodium and potassium transport across that cell membrane, and it also helps to assist in the contraction of cardiac and skeletal muscles. So how does our body regulate magnesium? Well, the GI system and the urinary systems regulate magnesium through absorption, excretion, and retention. So if our magnesium levels drop, the GI tract may absorb more magnesium, and if magnesium levels rise, then the GI tract is going to excrete more in the feces. The kidneys help to balance magnesium by altering reabsorption. So if our magnesium levels are high, the kidneys are going to do what? They're going to excrete it, get rid of it, and put the excess in the urine. If the magnesium levels start to fall, then the kidneys are going to hold on to that magnesium. They won't excrete it, so that way the magnesium levels can rise. So what patients can have hypomagnesia? Hypermagnesemia, which is less than 1.3. So patients that have chronic alcoholism, patients that have diabetic ketoacidosis, patients with renal disease, right? If their kidneys aren't functioning properly, they can't hold on to it. Severe burns, patients that have severe malnutrition, they're not getting it in their diet. Pregnancy-induced hypertension. So low magnesium levels actually causes pregnancy-induced hypertension for those pregnant women. Intestinal malabsorption syndrome. So remember last slide back, we said that our GI system will hold on to magnesium or excrete it depending on the levels. So if we have issues absorbing food in our intestines, well, then we can't regulate that process. Excessive diuresis, so we're treating those congestive heart failure patients, pulling all that fluid off with diuretics, so we're getting rid of our magnesium. Prolonged gastric suctioning, we're pulling all their stomach contents out, so we're getting rid of the magnesium. And then hyperaldosteroidism. So you will also see these signs that we talked about earlier also with your magnesium, okay? Nursing interventions. We want to aid in helping to bring up the magnesium levels. So we want to monitor patients receiving hyperalimentation without magnesium added. We want to put our patients on cardiac and seizure precautions because we said it can cause arrhythmias. It's going to affect the heart. So we're going to have them on that telemetry monitor those ECGs. We're going to administer, when administering magnesium, if the deep tendon reflexes are absent, we're going to hold that dose and we are going to notify the doctor. And then we're going to teach about foods that are high in magnesium. So if we're educating our patients, we're going to tell them to eat green leafy vegetables, whole grains, especially that wheat, germ, and bran, nuts, cocoa, chocolate, soybeans, seafood, dried peas, and then beans, all high in magnesium. We can give magnesium chloride. We can give it PO, 270 to 400 milligrams a day. We also have a sustained release formula, which will go throughout the period of the day. 535 milligrams. Side effects of these medications are diarrhea and sweating. And we advise them to not take this medication within 2 hours of other medications. So if you're doing your morning med pass and you see that your patient's getting medications along with some other medications, you probably want to give those first or last, depending on the situation with their magnesium, how low it is. We can give magnesium sulfate. It goes IV. It's always on a pump. It never, ever goes any faster than 150 mg. It's usually 100. You're going to want to monitor their vital signs and their deep tendon reflexes. So that's their patellar reflex during administration. You're going to be watching for a decrease in their deep tendon reflex. That is a bad sign. And then you're going to monitor their serum magnesium after each administration. So they usually get in the hospital, we call it a mag run. So if your patient's ever getting potassium replacements or magnesium replacements, we say my patient got a mag run or a potassium run. It's multiple bags of potassium, or in this case, magnesium. So usually after you administer the appropriate amount of magnesium, then the doctor about 2 or 3 hours later will order to look at the magnesium, or the next day, depending on how soon he wants to know, to make sure that those levels are rising. So hypermagnesemia, which is a magnesium level higher than 2.1. So this can be from trying to bring up the magnesium from the low magnesium status, and we cause this problem now. Excess use of antacids or laxatives. It can come from hyperalimentation, patients that are on hemodialysis. So hyperalimentation is just artificial supply of nutrients. So if we usually do this to patients who are that suffer from alcoholism. It prevents them from being able to absorb certain vitamins. So they get a lot of like what we call banana bags, which is these yellow bags of IV fluids filled with all these vitamins. So sometimes it comes from that. Hemodialysis, hyperthyroidism. So remember hyperparathyroidism. Sorry, remember we said the parathyroid hormone regulates that magnesium, right? Because it controls the renal absorption. So if it's overworking, then you're going to have too much magnesium. Same thing if it's underworking, you're not going to have enough. If you're not excreting it properly, so it could be due to reduced renal output or renal failure. All right. So signs and symptoms. We are going to see flushing. They're going to be very warm. They're going to have hypotension, low blood pressure. They may have nausea and vomiting, lethargy. They're going to be drowsy, bradycardic, low heart rate, less than 60, muscle weakness. Their respirations may be depressed. They could even go into a coma, and then you want to watch for these absent patellar reflexes. Okay, that's a bad sign. So if you see that in your patient, you're going to want to call the doctor right away. You guys need to know that. You're going to see that again on your test. So nursing interventions. Check medications for magnesium content. What is the patient taking outside? Looking at that over-the-counter stuff, looking at the CAM. What else is the patient taking that could have magnesium in it? Treat the underlying cause, and hopefully it's going to correct the balance. You want to increase their oral fluid so you can decrease the concentration of the magnesium. You're going to administer IVs, right? IV fluids to flush out that magnesium. You're going to keep them on the telemetry monitor cardiac status. And if it's an emergency, you can give calcium gluconate, because calcium gluconate is a magnesium antagonist. So this is just a side-by-side comparison of hypomagnesemia and hypermagnesia. So for hypo, you're going to have confusion, increased deep tendon reflexes, neuromuscular irritation, seizures, muscle cramps, tremors, insomnia, tachycardia. Hyper, you're going to have flushing, decreased deep tendon reflexes, muscle weakness, lethargy, decreased respirations, the opposite of tachycardia. So you're going to have bradycardia and hypotension. Phosphorus is the primary anion in the intracellular fluid. It is negatively charged. 85% of our phosphorus exists in bone and teeth, plays a role in cell membrane function, muscle function, neurologic function, and the metabolism of our carbohydrates, fats, and proteins. The normal value is going to be 2.57 to 4.5. And remember, we said it is closely related to calcium. They're on opposite ends of each other. So if calcium is up, phosphorus is down. If calcium is down, phosphorus is up. Recommended daily requirement is 800 to 1200 milligrams a day. So how does our body regulate phosphorus? So the amount that we have in our body is going to be directly related to the amount that we take in our diet. Our hormone regulation and excretion from our kidneys. And then when we think about transcellular shifts, phosphorus is going to be absorbed in our GI tract. And most of our phosphorus is absorbed in the area called the jejunum. As our kidneys regulate those serum levels of phosphorus, about 90% of it is going to be excreted from our kidneys. If our dietary intake is going to increases in phosphorus, then the kidneys increase the amount that they have to excrete because they want to keep that normal level. If we don't take in enough through our diet, then our kidneys are going to say, hey, we're not getting enough. They're going to hold onto it and they're going to reabsorb more. And the reabsorption occurs in those proximal tubules. So PTH and phosphorus. So the parathyroid gland controls the hormonal regulation of our phosphorus levels, and it affects the activity of our parathyroid hormone. So when we have a change in our calcium level, rather than our phosphorus level, it will affect the release of PTH. Remember, calcium and phosphorus are closely related. Calcium decreases, your phosphorus increases. So the parathyroid gland will release PTH, which causes an increase in calcium, and then phosphorus will be reabsorbed into the bone, and then both of your levels are going to rise. Okay, does that make sense? Calcium level goes down, phosphorus goes up. It's going to cause our phosphorus gland to release PTH, which causes an increase in the calcium and phosphorus reabsorption into the bone. So both of your levels will rise. PTH affects serum phosphorus levels by increasing our phosphorus release from the bone, increasing phosphorus absorption from our intestines, and then it's going to decrease the amount that our kidneys reabsorb from the renal tubules, okay? So low phosphorus is going to be less than 2.5 milligrams or 1.8 milliequivalent. Abnormal absorption causes hypo levels. Alcohol withdrawal can also cause hypophosphatemia because it causes a shift of phosphorus into the cells when the patients don't have alcohol in their system. We see this in patients that have diabetic ketoacidosis, patients that hyperventilate, so patients that are having respiratory issues, or if they're anxious and they're hyperventilating, it's going to cause a shift of phosphorus into these cells. So that way their extracellular fluid doesn't have any. Insulin release, so hyperglycemia, high blood sugar, causes the release of insulin, which transports glucose and phosphorus into the cell at the same time. We're going to see low levels when we're giving diuretics. We're pulling all those fluid and electrolytes off. Patients that don't have good nutritional intake, anorexia, if they're starving, malabsorption syndrome, so they're not absorbing the proper nutrients from their diet, and then those medications, so our antacids, our insulins, our laxatives, and our diuretics. So what signs and symptoms will we see? They're going to be irritable. They're going to be tired, fatigued. They're going to be very weak. Paresthesias, they're going to have numbness and tingling in their hands or their feet or in their face. They're going to be confused, might even see, in worst case scenarios, seizures, and then of course, coma is always an option as well. Nursing implications, we're going to monitor their vital signs. We're going to monitor their muscle strength and their neurological status. We're going to administer oral supplements. Some of these oral supplements may cause diarrhea. They don't have a great taste. You can always put them in juice. These patients might be on fall risk precautions because they're weak and they're confused. So they're going to have those bed alarms on. And then you want to encourage them to include things in their diet that is going to bring phosphorus in. So eggs, nuts, whole grains, fish, poultry, and milk products. So now we have hyperphosphatemia. So this is an increase in phosphorus levels greater than 4.5 milligrams or 2.6 milliequivalents. So we will see these patients will have anorexia. They're not going to be hungry, no appetite. They are also going to have that positive Chvostek or Trocio sign. They're going to have a decreased mental status. So they might not be alert and oriented ×4. They might need reorienting to their environment, date, time, situation. They're going to have hyperreflexia. They're going to have muscle weakness. They might complain of cramps or spasms. They're going to have tetany, and they're going to be tachycardic. So everything is going to be excited, hyper. So what can cause it? Acidosis can cause it. Patients that have renal failure, their kidneys can't work right, so those levels are going to increase. Patients that have low calcium, right? Because these two are on the opposite ends of each other. Sometimes if we give patients massive blood transfusions, like in shock trauma, things like that, where they're getting multiple bags, we'll see this. And then of course, those patients with hyperparathyroidism. So what do we want to do to fix the problem? We want to assist in correcting whatever that underlying cause is. We're going to monitor their vital signs. They're going to be on telemetry monitor. We're going to be watching their heart rate. For patients that have severe hyperphosphatemia, they might need IV saline to help promote renal excretion of the high potassium. And then chloride, so normal chloride levels are 97 to 107 milliequivalents per liter. It is the most abundant anion in the extracellular fluid, helps maintain osmolality and water balance. It is closely related to sodium. So when you have a change in one, it's going to cause a very comparable change in the other. So if your sodium is low, then your chloride is probably going to be low too. It has an inverse relationship with sodium bicarb, HCO3. If your chloride is elevated, then your sodium bicarb is going to be decreased. So a comparable change relationship with sodium and chloride, but then an inverse relationship with chloride and sodium bicarb. Chloride is going to be found in our sweat. We find it in the GI tract, and we find it in the kidneys. So just by looking at that statement, we know that any patient that is going to have any kind of GI issue, so if they're having vomiting, they're having diarrhea, we're doing suctioning on them, they are going to have abnormal chloride levels one way or another, depending on what's going on. If their kidneys are not working properly, we already know that they are at risk for suffering from hypo or hyper levels of chloride, right? Because we've been talking about this all night. So hypokalemia, excessive losses come from patients that have prolonged vomiting, if they have severe diarrhea, if they have severe diaphoresis, so severe sweating, if they have burns, gastric surgeries, NG tube suctioning, GI tube drainage, and then of course, diuretics. You won't really see the symptoms of hypokalemia, but instead it's going to be hyponatremia. Remember, we said that they coincide together. So if you have low chloride, you have hyponatremia as well. So those are the signs that you're going to see. So you're going to see those hyperactive deep tendon reflexes. You're going to see the muscle hypertonicity. You might see tetany, and then your patients are also at risk for developing metabolic alkalosis. We're going to be talking more about that next week. So remember, you're not really going to see those signs and symptoms of the low chloride. It's going to be the hyponatremia that you're seeing because those levels are going to be low together. So causes of hypochloremia, nasogastric suctioning, vomiting, kidney disease, and then heart failure. Nursing implications, we're going to want to treat whatever the cause is. We can fix it. We can put things back to where they need to be. We're going to give chloride replacements. We can do this through IV or PO. We're going to monitor their I's and O's, everything they take in, everything they put out. We can give IV fluids. Normal saline is usually what we give. Monitor those vital signs. Monitor that cardiac function because hypokalemia can also occur sometimes with hypochloremia. So those patients are going to be on heart monitors, going to be looking for abnormal ECGs, abnormal rhythms, irregularities. And then, of course, we're going to monitor their electrolytes, right? Something we're doing with everything, with all these electrolytes. So hyperchloremia, which is chloride levels greater than 107. And with the same thing with the hypo, you're only going to notice the symptoms of hypernatremia. So you're going to see arrhythmias, you're going to see decreased cardiac output, and then a decreased level of consciousness. So here, just a cute little cartoon, we can be together at low levels with metabolic acidosis as a result of bicarbonate deficits. That doesn't make a lot of sense to you now, but it will after next week. Ingestion of excessive chloride infrequently accompanies the use of ammonium chloride, diuretics. So there we are, sodium and chloride go together. Say cheese, popcorn, bread, and other high salt foods. So we need to watch for increased sodium and decreased bicarbonate levels, which lead to too much chloride. Because remember we said chloride and bicarbonate are inverse of each other. Nursing implications, we want to correct the underlying cause and then correct the fluid volume balance. All right, I can't believe it. We actually finished